Okay, let's unpack this. Imagine an organ tucked away under your left ribs, one that for centuries was, well, dismissed by doctors, sometimes even removed without a second thought if it just seemed inconvenient.
Hmm.
You might not think much about it day to day, but modern medicine has completely rewritten its story.
It really has.
It turns out this seemingly minor player is actually a vital, complex powerhouse, absolutely essential for critical bodily functions.
That's right. We're talking about the spleen and the journey to truly understanding its importance, its intricate workings, and the profound impact its absence can have. That's a fascinating one.
It really is.
Today, we're embarking on a deep dive, taking the detailed medical text you've shared and dissecting it like seasoned experts in the field.
We're going to explore every concept presented in this material, going beyond the surface facts to grasp the fundamental why and how. We want to master this information, understanding the spleen from its very origins through its astonishing anatomy and physiology.
The myriad ways diseases involve it, how we investigate those problems, and what happens when surgery is necessary.
Exactly. Think of this as your guide to knowing the spleen like an elite professional.
Our mission is to take this dense information and make it not just digestible, but truly insightful, highlighting the connections, the surprising details, and the clinical relevance that makes this organ so compelling.
All right, let's start at the very beginning. If we're talking about mastering the spleen, we need to understand where it comes from. How does this vital organ even form during development?
It's quite interesting because its origins are linked to the gut. The spleen develops from condensations of mesenchymal tissue. This happens within the dorsal mesogastrium.
The dorsal mesogastrium, remind us what that is.
Right, so the dorsal mesogastrium is a fold of the peritoneum, that's the membrane lining your abdominal cavity that connects the dorsal or back body wall to the developing stomach in the embryo.
So it starts off connected right there to the stomach.
Precisely. And this developmental process in the dorsal mesogastrium is key because it sculpts the ligaments that will attach the spleen in its adult position.
Ah, okay.
As the stomach rotates and the mesogastrium grows, the mesenchymal condensation that forms the spleen divides this fold. One part becomes the gastrosplenic ligament, connecting the spleen to the greater curvature of the stomach.
Right.
The other part becomes the lenarenal ligament, connecting the spleen to the left kidney.
That anatomical relationship, set up so early in development, must be incredibly important later on, especially for surgeons working in that area.
Oh, absolutely.
Why is knowing about these ligaments and what's in them so critical during surgery?
It's absolutely foundational knowledge for anyone operating in the upper abdomen. Take the gastrosplenic ligament, which is anterior to the spleen's hilum in an adult.
Okay.
This ligament doesn't just hold the spleen to the stomach, it acts as a conduit for blood vessels. It contains the short gastric arteries and the left gastropiploic artery, all branches of the splenic artery.
Oh.
So if a surgeon is performing a gastrectomy, removing part of the stomach, particularly along the greater curvature, they must divide these vessels within the gastrosplenic ligament. Knowing they are there is vital for safe surgery, requiring careful ligation to prevent serious bleeding.
Okay, so that ligament connects the spleen to the stomach and carries vessels needed by the stomach. What about the lenarenal ligament connecting the spleen to the kidney?
The lanarenal-splenorenal ligament is posterior to the splenic hilum. It connects the spleen to the anterior surface of the left kidney. And this is where it gets really anatomically significant for major abdominal surgery.
Right.
The main splenic artery and the main splenic vein, the lifeline of the spleen, are contained within this ligament.
Oh, wow.
And critically, the tail of the pancreas is also nestled within the layers of the lanarenal ligament, running right up to the splenic hilum.
Wow. So the main blood supply to the spleen and the very end of the pancreas are all bundled together in that one ligament.
Exactly. During a splenectomy surgical removal of the spleen, or during procedures on the distal pancreas, the surgeon must carefully divide this lenarenal ligament.
Makes sense.
Often, they start by dividing the posterior layer to mobilize the spleen. The close proximity of the pancreatic tail to the splenic vessels within this ligament is a major reason why pancreatic injury, like a pancreatic fistula, is a known complication of splenic surgery. Understanding this intimate relationship, established embryologically, is crucial for avoiding complications.
That really paints a picture of how delicate surgery in this area can be. The embryology dictates the adult connections, and those connections hold key structures that are vulnerable during intervention.
Let's talk about the adult anatomy more broadly. What does a healthy spleen look like, and where is it precisely located?
In a typical adult, the spleen is quite small compared to organs like the liver. It generally weighs between 75 and 250 grams and measures roughly 10 centimeters long, 7 centimeters wide, and maybe 3 centimeters thick.
It sits in the left hypochondrium, that's the upper left part of your abdomen, tucked away mostly under the rib cage.
So it's pretty well protected then.
Yes, its location is largely posterior and lateral, nestled against the left hemidiaphragm superiorly, the gastric fundus of the stomach anteriorly, and the left kidney posteriorly and inferiorly. Its longest dimension usually aligns with the axis of the 10th rib.
Right.
This protected location is why, in its normal size, you can't feel your spleen during a physical exam.
And how much does it have to enlarge before it becomes palpable?
For a doctor to feel your spleen below the costal margin, the edge of your ribs, it typically needs to enlarge significantly, by about threefold its normal size.
3 times. Okay.
So a palpable spleen is a clear clinical sign of splenomegaly or splenic enlargement, prompting further investigation.
Going back to its physical connections, we've covered the gastrosplenic and leonorenal ligaments containing those vital vessels in the pancreatic tail. Where is the hilum located, where the vessels enter and leave?
The splenic hilum is essentially the gateway to the spleen for its blood vessels and nerves. It's situated on the medial or inner surface of the spleen, typically located right there in the angle formed between the greater curvature of the stomach and the anterior surface of the left kidney. As we emphasize, this is where it makes close contact with the tail of the pancreas. The spleen also has a concave visceral surface that kind of molds to the shapes of these adjacent organs.
Are there any other external landmarks?
Yes, there's often a notch found on the inferolateral border of the spleen. While it's not always present or prominent, this notch can sometimes be felt during palpation if the spleen is markedly enlarged, serving as another indicator of splenomegaly.
Let's trace the blood supply in more detail, because it's quite distinctive, isn't it?
It is. The spleen receives its blood from the splenic artery, which is the largest branch of the coeliac axis, the main artery supplying the upper abdominal organs. The splenic artery is notorious for being quite tortuous, or winding, as it runs along the superior border of the body and tail the pancreas, giving off small branches to the pancreas as it goes.
And before it even gets to the spleen, it gives off those branches to the stomach we mentioned.
Exactly. As it travels along the pancreas, it sends off the short gastric arteries and the left gastroepiploic artery. These vessels travel within the gastrosplenic ligament to supply the stomach. As we noted, they are crucial to identify and ligate during certain gastric procedures.
So the main artery reaches the hilum.
At the splenic hilum, the main splenic artery typically divides into 2 large branches, a superior and an inferior branch.
Okay.
These then further subdivide into several smaller segmental arteries within the spleen substance. This pattern of segmental branching is actually very important from a surgical standpoint. Because the spleen has these distinct vascular segments with relatively little crossover between them, it means that in certain situations like trauma involving only one part of the spleen, or maybe a cyst confined to a segment, it's sometimes possible to perform a partial splenectomy.
Ah, removing only the affected part.
Exactly, removing only the affected segment while preserving the function of the rest of the organ. This is a key concept in modern splenic surgery conservation.
That makes sense. The blood supply is divided into zones, allowing for targeted intervention. How does blood leave the spleen?
Blood leaves via the splenic vein. This vein is formed by the confluence of multiple tributaries draining the splenic pulp, emerging from the hilum. Unlike the artery, the splenic vein runs a straighter course, traveling behind the body and tail of the pancreas.
Behind the pancreas, okay.
Along the way, it receives several small veins draining the pancreas.
And where does the splenic vein lead?
It travels medially behind the pancreas, and at the neck of the pancreas, it joins up with the superior mesenteric vein to form the portal vein.
Ah, so the splenic vein is a major contributor to the portal vein system, which carries blood from the stomach, intestines, spleen, and pancreas directly to the liver.
Precisely. And this direct connection means that the spleen circulation is intrinsically linked to the pressure dynamics within the portal system.
Right.
Changes in portal venous pressure, such as those seen in liver cirrhosis, have a direct impact on blood flow and pressure within the spleen.
Let's look inside the spleen now. What is its internal structure like that allows it to perform its complex functions?
Well, the spleen is covered by a fibroelastic capsule internally, with an outer serous coat. From this capsule, connective tissue extensions called trabeculae penetrate into the spleen substance.
Trabeculate.
These trabeculae provide structural support, forming a kind of framework within the splenic pulp. They also carry the blood vessels deeper into the organ.
And the parenchyma, the pulp itself, what's that made of?
The splenic parenchyma, or pulp, is the functional tissue of the spleen, supported by the trabeculae and a fine reticular network. It's divided into two distinct components, each with different functions, the white pulp and the red pulp.
Okay, two main zones. Let's start with the white pulp. What's its structure and role?
The white pulp is essentially the spleen's immune tissue. It's organized around the central trabecular arteries that enter the spleen. Surrounding these arteries are areas known as periarterial lymphatic sheaths, which are packed with T lymphocytes.
T cells.
Adjacent to these sheaths are lymphatic nodules, which are rich in B lymphocytes and contain germinal centers. These are the sites where immune responses are initiated and B cells proliferate and mature into antibody-producing cells.
So the white pulp is where the spleen mounts its organized adaptive immune responses against pathogens in the bloodstream.
Exactly. That's the hub of the adaptive immune response in the spleen.
And the marginal zone on the edge of the white pulp, what does that do?
The marginal zone is a key transition area at the boundary between the white pulp and the surrounding red pulp. Blood from the arterioles leaves the white pulp and filters through the marginal zone sinuses.
Okay.
This area is rich in specialized macrophages and B cells and acts as a first point of contact and filtration for blood-borne antigens and particles. Macrophages here efficiently capture and phagocytose foreign material circulating in the blood.
So it's like an initial screening?
Kind of. And this is also where immunoglobulins, particularly IgM produced in the white pulp, enter the systemic circulation via the marginal zone sinuses.
So the white pulp is the spleen's surveillance and rapid response center for blood-borne threats.
Exactly. It's constantly sampling the blood for antigens and initiating immune reactions.
Now the red pulp, which sounds like where the filtration happens.
The red pulp makes up the majority of the splenic volume and is primarily involved in filtering the blood, particularly blood cells. It consists of two structural components, the splenic cords, also called the cords of Billroth, and the splenic sinuses.
Cords and sinuses.
Blood flows from the white pulp and enters the red pulp cords.
And how does blood get from the cords into the sinuses? This is where that unique filtration process comes in, right?
This is the core of the spleen's mechanical filter function. The spleen has a dual circulation system, but the dominant one is the open circulation. About 90% of the blood leaves the arterioles in the red pulp and enters the cords, which are essentially a spongy network of tissue packed with macrophages.
Okay.
From these cords, the red blood cells must then squeeze through narrow slits or fenestrations in the walls of the splenic sinuses to re-enter the venous circulation.
So red cells literally have to deform and change shape to get through those tiny openings.
Precisely. They must be able to elongate and become significantly thinner to navigate this passage from the cords into the sinuses. This physical barrier acts as a rigorous quality control check for red blood cells. Healthy, flexible red cells can make the journey, but cells that are abnormally shaped, rigid, or contain inclusions have difficulty squeezing through, get trapped in the cords, and are then recognized and destroyed by the abundant macrophages in the red pulp.
That's incredible. It's not just passive filtering, it's an active process that requires healthy cell mechanics, like a bouncer checking IDs at the cellular level.
It is. It's a very active process. There's also a smaller closed circulation where about 10% of blood flows directly from arterioles into sinuses, bypassing the cords, but the open circulation is responsible for the extensive filtration and cell checking.
And the pressure within this system, does that tell us anything?
Yes, because the open circulation involves blood essentially flowing through the tissue spaces of the cords before entering the low-pressure sinuses. The pressure within the splenic pulp reflects the pressure within the entire portal venous system.
Ah, connecting back to the portal vein.
Exactly. This is why splenic enlargement and congestion are characteristic features of portal hypertension. The normal blood flow through this intricate system is quite high, estimated at around 300 milliliters per minute.
So the spleen is built with this amazing internal architecture, combining immune surveillance with a unique blood filtration system that even physically tests the quality of your red blood cells. It's clearly doing a lot more than just sitting there.
Absolutely. That historical view of it being unimportant or dispensable really stands in stark contrast to our modern understanding of its critical roles.
Yeah, you can see why.
Preserving splenic function is now a major goal in surgical and medical management whenever possible, because its absence carries significant risks.
Let's delve deeper into those specific functions and why they are so vital. The immune function is clearly paramount.
It is. As we saw in the white pulp, the spleen is a major lymphoid organ, housing a significant portion of your immune cells, approximately 70.5% of your total T lymphocytes and 10-15% of your total B lymphocytes.
That's a huge proportion.
It is. It's a key site for identifying and processing foreign antigens present in the bloodstream, acting as a central meeting point for blood-borne immune responses.
And its role in antibody production. You mentioned IgM.
The spleen is the primary site for the production of specific IgM antibodies. These are particularly important in the initial immune response to certain types of pathogens. Additionally, the spleen synthesizes non-specific opsonins.
Opsonins, what do they do exactly?
Opsonins are molecules like properdin and tufsin that essentially tag or coat microorganisms and other particles in the blood.
Okay, like putting a label on them.
Exactly. This tagging makes them much easier for phagocytic cells like macrophages and neutrophils to recognize and engulf. These opsonins bind to specific receptors on those immune cells, stimulating their phagocytic, bactericidal, bacteria-killing, and even tumoricidal, tumor cell killing activity.
So the spleen helps create antibodies and boosts the ability of other immune cells to find and destroy threats.
Exactly. It's enhancing both the specific antibody response and the non-specific cellular immune defense, particularly against pathogens circulating in the blood.
And the critical implication of losing this is where the danger comes in, right?
This is the major risk of not having a functional spleen. The loss of these crucial immune functions, particularly the production of IgM and certain opsonins, and the impaired ability to filter encapsulated bacteria from the blood, dramatically increases the risk of severe, overwhelming infections.
Why are capsulated bacteria such a problem for someone without a spleen? What's special about them?
Bacteria like Streptococcus pneumonia, Neisseria meningitis, and Haemophilus influenza type B have a tough outer polysaccharide capsule. This capsule makes it difficult for phagocytes to engulf them directly. It's like a slippery coating.
Yeah.
The immune system relies heavily on antibodies, especially IgM, and opsonins produced by the spleen to coat these bacteria, making them visible and tasty for macrophages and neutrophils to clear from the bloodstream. Without a spleen, this clearance mechanism is severely compromised, allowing these bacteria to multiply rapidly in the blood and cause life-threatening septicemia and meningitis. This is why vaccination against these specific organisms is absolutely vital after splenectomy.
That makes the connection crystal clear. The spleen's specific immune tools are indispensable for handling these particular bacterial threats. Let's look back at the filter function, adding more detail on what specifically is filtered out.
Right. Beyond filtering pathogens, the spleen's red pulp, with its macrophages in the cords and sinuses, acts as a crucial filter for cellular debris and aging blood cells. It's constantly removing effete, or old and worn out, platelets and red blood cells in circulation.
Okay.
These cells are trapped in the red pulp cords or sinuses and are then phagocytosed by the endothelial macrophages lining the sinuses and the macrophages in the cords.
And what happens to the components of the old red cells? Does anything get reused?
Yes, the spleen is very efficient at processing them. When red blood cells are broken down, it removes the iron from the degraded hemoglobin and recycles it, returning it to the plasma so it can be used by the bone marrow to make new red blood cells.
Efficient recycling. And the removal of other non-cellular material.
Yes, debris and other particles in the blood are also captured and cleared by the splenic macrophages. This comprehensive filtering process, combined with the mechanical test of deformability in the open circulation, is why the spleen is so important for maintaining the health and quality of your circulating blood cells.
That filtration mechanism, especially the deformability check, explains why conditions affecting red cell shape or flexibility cause problems with the spleen, like hereditary spherocytosis you mentioned.
Exactly. In hereditary spherocytosis, there are genetic defects in the proteins that form the red cell membrane skeleton, things like spectrin, ankyrin, band 3, protein 4.2. These defects make the red cells abnormally rigid and spherical, instead of their usual flexible biconcave disc shape. When these rigid spherocytes try to squeeze through the narrow slits from the red pulp cords into the sinuses, they get trapped, damaged, and prematurely destroyed by the splenic macrophages.
So the spleen is just doing its job, but the abnormal cells can't pass the test.
Precisely. The spleen's normal filter function, when presented with these defective cells, becomes the primary site of excessive red cell destruction, leading to anemia. And removing the spleen stops this excessive destruction.
Right, removing the filter allows the defective cells to circulate longer.
Exactly, improving anemia, even though the underlying cellular defect remains.
You mentioned pitting earlier as a unique process. How does that work? It sounded fascinating.
Pitting is a remarkable function that showcases the spleen's ability to repair red blood cells. It's the process by which the spleen removes particulate inclusions within the red blood cell cytoplasm without destroying the entire cell.
Like tiny cleanups inside the cell, almost like editing them?
Yes, exactly. Think of it as a microscopic quality control or cleaning mechanism. Examples of these inclusions are Howell-Jolly bodies, which are remnants of the cell nucleus that weren't extruded completely during red blood cell maturation,
Okay.
or Heinz bodies, which are precipitates of denatured hemoglobin or globin subunits that can form in certain conditions like thalassemia or due to oxidative damage.
And where do you see these inclusions appear in circulating red cells, usually when the spleen isn't working?
You typically see these inclusions in the circulating red blood cells when the spleen is either absent or non-functional. After a splenectomy, Howell-Jolly bodies will appear in the blood.
Right.
In conditions like sickle cell disease, where repeated infarcts can lead to autosplenectomy, the spleen becoming fibrotic and non-functional. You'll also see Howell-Jolly bodies and possibly target cells on a blood smear. Heinz bodies are seen in thalassemias and certain drug reactions when the spleen can't remove them.
So the spleen normally pulls these out.
Exactly. The spleen, when functional, pulls these cells into the red pulp cords. The macrophages extract the inclusion, and the cell, minus the inclusion, is returned to circulation.
So the spleen can actually modify and repair the red blood cells. That's truly an elite level function. And the text even nods to the history here, mentioning figures like Howell, Jolly, and Heinz associated with these discoveries.
It highlights how detailed our understanding of this organ's microfunctions has become over time.
The spleen also has a reservoir function, right? How much blood does it actually hold? Is it significant?
In humans, the reservoir function is less prominent compared to some animals like dogs or horses, where the spleen can store and release a large volume of red cells quickly. A normal human spleen holds only about 8% of the total red cell mass.
Okay, so not a huge reserve normally, but does this function become more significant in disease?
Absolutely. This function becomes clinically relevant when the spleen is massively enlarged or splenomegaly. An enlarged spleen can sequester or hold on to a much larger proportion of the total blood volume, including not just red cells, but also white blood cells and platelets.
And how does that cause problems if it's holding on to too many cells?
This sequestration of blood cells within a massively enlarged spleen can lead to pancytopenia, a reduction in all three major cell lines, red cells, white cells, platelets, in the circulating blood. This is a key component of hypersplenism.
Right.
In these cases, removing the enlarged spleen via splenectomy can often correct the pancytopenia by releasing the sequestered cells back into circulation.
So the reservoir function, while small in a healthy state, can turn into a major issue contributing to low blood counts when the spleen becomes pathologically large.
Precisely. It demonstrates how normal physiology can contribute to pathology when the organ itself is diseased.
Finally, the text mentions cytopoiesis. Doesn't blood cell formation primarily happen in the bone marrow in adults?
Yes, in adult humans, the bone marrow is the primary site of hemopoiesis, or blood cell formation. However, during fetal development, the spleen plays a role in hemopoiesis, starting from about the 4th month of intrauterine life. In adults, the spleen retains the potential for cytopoiesis.
Under what conditions would it start producing blood cells again?
While antigenic challenge can stimulate the white pulp's lymphocytes and macrophages, true extramedullary cytopoiesis blood cell production outside the bone marrow can restart in the spleen in certain pathological conditions.
Like when the marrow isn't working properly.
Exactly, or when it's massively overactive in an abnormal way. This is typically seen in severe hematological disorders, such as myeloproliferative disorders, severe thalassemias, and chronic hemolytic anemias.
So in these diseases, the spleen reverts to a fetal role, becoming a site of blood cell production in addition to its filtering and immune roles.
Exactly. This extramedullary hemopoiesis often contributes significantly to the splenic enlargement seen in these conditions. It shows the spleen's developmental plasticity and its capacity to take on roles normally performed elsewhere when the body is under severe stress or battling certain diseases.
We've covered how the spleen is formed, what it looks like inside and out, and its incredible range of functions. Now, how do doctors actually figure out if there's a problem with this hidden organ? How is the spleen investigated?
Investigation typically begins with clinical assessment, taking a careful history and performing a physical examination. As we discussed, detecting splenomegaly, or an enlarged spleen, during palpation is a key finding that suggests splenic pathology.
Though you need that threefold enlargement first.
Right, though remember, the spleen has to be quite large to be felt.
And laboratory tests. What blood work is relevant?
Laboratory tests are crucial for identifying underlying conditions that might involve the spleen, particularly blood disorders. If a hemolytic anemia is suspected, blood tests would include a complete blood count to check for low red cells, a reticulocyte count to see if the bone marrow is producing new red cells to compensate,
Right.
and specific tests to identify the type and cause of the red cell destruction.
What if portal hypertension is suspected?
If splenomegaly is thought to be due to portal hypertension, often related to liver disease, lab work would focus on liver function tests, assessing for anemia, leukopenia, and thrombocytopenia indicative of hypersplenism, and potentially examining for signs of liver dysfunction like ascites.
And endoscopy.
Endoscopy might be needed to visualize esophageal varices, which are swollen veins in the esophagus caused by portal hypertension and a significant risk of bleeding.
The text also mentions non-cirrhotic portal fibrosis. How is that different?
Yes, this is an important cause of massive splenomegaly and pancytopenia in tropical countries, often linked to infections like schistosomiasis. Crucially, these patients typically do not show the signs of liver dysfunction seen with cirrhosis, distinguishing it clinically.
Okay. And segmental portal hypertension, where only the splenic vein is blocked.
That's another scenario. Isolated occlusion of the splenic vein, perhaps due to thrombosis or compression by pancreatic inflammation or a tumor, leads to increased pressure only in the splenic vein and its tributaries.
So just affecting the spleen and nearby veins.
Right, causing splenomegaly and often varices limited to the stomach and lower esophagus. This is distinct from widespread portal hypertension from liver disease.
If splenomegaly is found along with enlarged lymph nodes elsewhere in the body, what does that suggest?
That combination immediately suggests a systemic disease affecting both the spleen and lymphatic system, commonly seen in conditions like lymphomas or leukemias. Further investigation, often involving a lymph node biopsy, would be needed to make a specific diagnosis and guide treatment.
Beyond a clinic and lab, imaging is indispensable for seeing what's going on inside, right? You need pictures.
Absolutely. Radiological imaging provides a visual roadmap of the spleen and helps characterize any abnormalities. Plain X-rays aren't typically used for direct splenic assessment, but sometimes they can incidentally show calcifications within the spleen or splenic artery.
What might calcification mean? Is that always bad?
Not necessarily bad, but it tells you something happened. Calcification in the splenic area could indicate a calcified splenic artery aneurysm, an old infarct, a benign cyst with calcified walls, a parasitic hydatid cyst, which often have characteristic rim calcification,
Hi.
or if multiple small calcifications are scattered throughout the spleen, it might suggest healed splenic tuberculosis.
What about ultrasound?
Ultrasonography is often a first-line imaging tool. It's quick, non-invasive, and effective for determining the spleen size, assessing its general consistency, and identifying whether large, simple cysts are present.
And CT scans. They seem common for abdominal issues.
Computed tomography, particularly with intravenous contrast, is much more detailed and commonly used for characterizing splenic pathology. It provides excellent spatial resolution and allows for a comprehensive assessment of the entire abdomen to identify associated issues.
What kinds of things show up clearly on a CT? The text includes figures showing cysts, hydatid disease, pseudocysts, infarcts, abscesses, portal hypertension.
CT is excellent for these. Cysts, abscesses, and infarcts typically appear as areas within the spleen that are less dense than the surrounding normal splenic tissue after contrast injection. They're often described as low density or hypodense lesions.
Okay, darker areas, basically.
Right. Hydatid cysts can have specific appearances like internal septations or rim calcification. Pseudocysts, often related to pancreatic issues, are usually fluid-filled collections near the pancreatic tail, displacing the spleen. Splenic infarcts show a characteristic wedge-shaped area of no contrast uptake. In portal hypertension, CT shows the enlarged spleen along with dilated portal and splenic veins and sometimes portosystemic collateral vessels.
And MRI. Is it used often for the spleen?
Magnetic resonance imaging is also very valuable and can offer superior tissue characterization in some cases. Specific MRI sequences, like T2-weighted images, are particularly sensitive to fluid and can clearly delineate cystic lesions, which appear bright, hyperintense.
So bright on T2 means fluid.
Generally, yes. Solid lesions or areas of scarring might appear darker. Hypointense. MRI can be very helpful for visualizing subtle lesions, like the small hypointense areas seen in splenic tuberculosis, or the diffuse changes and massive size in myelofibrosis.
So imaging gives doctors the ability to look inside and see the size, structure, and specific types of lesions affecting the spleen. Really essential tools.
Exactly. It's indispensable for confirming clinical suspicions, making specific diagnoses, and guiding treatment planning.
We've talked about acquired issues, but what about problems someone is born with? Congenital abnormalities of the spleen, are these common?
These are relatively uncommon compared to diseases that develop later in life. The most severe is splenomegaly, where the spleen simply fails to form at all during embryonic development.
Wow, completely missing.
Yes. This is quite rare as an isolated finding, but is seen more frequently in about 5% of cases in children born with complex congenital heart disease, suggesting a link in early developmental pathways.
Polysplenia is another rare one mentioned.
Yes. Polysplenia is a congenital condition where, instead of developing into a single spleen, the embryonic splenic tissue fails to fuse properly, resulting in multiple small spleens. This is often associated with other developmental abnormalities of the abdominal organs or heart.
But then there are splenunculi, or accessory spleens, which sound much more common.
Splenunculi are indeed much more common. They are small nodules of ectopic or misplaced splenic tissue located outside the main spleen. They are found in a significant percentage of the population, estimated to be between 10% and 30%.
10 to 30%, that's quite a lot.
It is. Their size is usually small, often only a couple of centimeters in diameter.
Where are they typically found? Scattered around.
Their location is varied, but often follows the path of embryonic development or the major splenic vessels. About half are found near the splenic hilum, closely associated with the splenic artery and vein.
Makes sense.
Another 30% are found near the tail of the pancreas, which also makes sense given the pancreatic tail's close relationship to the splenic vessels within the lean-renal ligament. The remaining accessory spleens can be found in other locations in the upper abdomen, including within the mesocolon, the greater omentum, or other splenic ligaments.
So they're a relatively common anatomical variation. What's their clinical significance? Why do surgeons need to know about them?
Their clinical significance is paramount in certain situations, particularly when splenectomy is being performed to treat a hematological disorder like idiopathic thrombocytopenic purpura, ITP, or certain hemolytic anemias.
Why is it so important then?
If an accessory spleen is present and not identified and removed during the main splenectomy, that accessory splenic tissue can hypertrophy, meaning it can enlarge over time and start performing the functions of the original spleen.
Oh.
This can lead to the recurrence of the patient's original disease symptoms, such as persistent low platelet counts in ITP.
So they can become the new spleen and cause the disease to come back. That's critical to know.
Exactly. Therefore, a meticulous search for and removal of accessory splenic tissue is a crucial step during a splenectomy performed for hematological indications to ensure the procedure's success and prevent symptom recurrence. This highlights how even seemingly minor anatomical variations can have major clinical consequences.
That's a powerful example of the level of detail needed for elite understanding in this field. Let's move into pathology when specific diseases afflict the spleen. We touched on some already, but let's go deeper, starting with hamartomas and cysts.
Splenic hamartomas are rare benign lesions. They are essentially disorganized collections of the normal cellular elements found in the spleen, but arranged abnormally, giving them a tumor-like appearance.
So not cancer, just disorganized tissue.
Right. They are usually incidental findings and vary in size. The text notes two forms. One predominantly composed of lymphoid tissue resembling white pulp, and another resembling red pulp tissue.
And splenic cysts, non-parasitic ones. Are they common?
Non-parasitic splenic cysts are also uncommon. A key distinction is made based on whether the cyst cavity is lined by an epithelium. Primary, or true, cysts do have an epithelial lining, whereas secondary or pseudocysts lack this lining.
Okay, true versus pseudo. What causes the true cysts?
True cysts are thought to arise from developmental issues, remnants of embryonic tissue left behind. This category includes things like epidermoid cysts, dermoid cysts, mesenchymal inclusion cysts, and cystic forms of benign vascular tumors like hemangiomas or lymphangiomas.
And they can get big.
They can be quite large, rarely even replacing almost the entire splenic parenchyma, as shown in one of the figures. Treatment usually involves splenectomy or partial splenectomy if the cyst is large, typically over 5 centimeters, or causing symptoms.
And the false cysts, the pseudocysts, where do they come from?
Pseudocysts are typically a consequence of trauma to the spleen, often developing within an area of organized hematoma or infarction. The walls are made of fibrous tissue, not epithelium. The fluid inside can be serous or contain evidence of old blood. The walls of traumatic pseudocysts can sometimes calcify, and interestingly, this calcification can make them look similar to hiated cysts on X-ray or CT scan, which is a diagnostic consideration.
The text specifically mentions pseudocysts related to pancreatitis. How common is that?
Yes, given the anatomical proximity of the pancreatic tail to the splenic hilum, the spleen is a relatively common site for the development of pancreatic pseudocysts following acute or chronic pancreatitis. These are diagnosed with imaging. Intervention is usually required if the pseudocyst is symptomatic, causing pain, pressure, or if it persists over time and is large.
So cysts are rare but need careful classification to understand their origin, which guides management, typically removal if large or symptomatic.
Precisely. Understanding the true versus false distinction is a key clinical detail here.
Now let's get into some more acute and potentially life-threatening pathologies. Splenic artery aneurysm, infarct, and rupture. Splenic artery aneurysms first. Are these common?
Splenic artery aneurysms are focal dilatations or bulges in the wall of the splenic artery. They are relatively uncommon, found in perhaps 0.04% to 1% of postmortem examinations, suggesting many go undetected during life.
Are there specific groups at higher risk?
They are about twice as common in women compared to men, and usually occur in the main trunk of the artery, though about a quarter of cases involve multiple aneurysms along the artery.
And the causes?
Causes include things that weaken the vessel wall, such as intra-abdominal sepsis, pancreatic necrosis from pancreatitis, which can erode into the artery, creating a pseudoaneurysm.
Oh, okay.
And in older patients, they are often associated with widespread arteriosclerosis.
Do they cause symptoms normally, or are they usually found by accident?
Most splenic artery aneurysms are completely symptomless and are discovered incidentally on imaging scans performed for other reasons. Very rarely, a large one might be palpable as a mass, or an audible bruit might be heard over it with a stethoscope.
The real danger, as with any aneurysm, is rupture. How serious is that?
And splenic artery aneurysm rupture is catastrophic. It is often unexpected and typically results in massive hemorrhage into the peritoneal cavity, causing acute abdominal pain and shock, symptoms that can mimic traumatic splenic rupture.
Who is particularly vulnerable to rupture?
Almost half of ruptures occur in patients younger than 45, which is notable, and about a quarter occur in pregnant women, usually in the third trimester or during labor.
Oh, that's incredibly dangerous in pregnancy.
Yes. Rupture in pregnancy carries an extremely high mortality rate for the mother and, sadly, almost inevitable fetal death.
That's devastating. How are these aneurysms treated then? Has the approach changed?
The approach has evolved significantly. Historically, treatment was surgical, often involving splenectomy, along with removing the aneurysm. Now, with advances in interventional radiology, endovascular techniques are often preferred, particularly for stable patients.
What do the endovascular techniques involve, like going in through the blood vessels?
Exactly. They involve selective splenic artery angiography to precisely locate the aneurysm, followed by procedures like embolization injecting coils or other materials to block flow into the aneurysm sac, or sometimes placing a stent across the weakened segment.
When is intervention indicated? Do you treat all of them?
Intervention, either surgical or endovascular, is generally indicated in younger, asymptomatic patients once an aneurysm is confirmed by imaging, CT, MRI, or angiography, due to their higher baseline risk of rupture.
Okay.
In elderly patients with calcified aneurysms, which are thought to have a lower rupture risk, observation might be preferred if the aneurysm is stable and not growing. The text shows an image of a pseudoaneurysm, which is a contained leak rather than a true aneurysm wall defect, often seen near the pancreas in cases of pancreatitis, illustrating this risk.
So rare but dangerous, especially in specific populations, with modern treatment favoring less invasive techniques. What about splenic infarction, tissue death in the spleen?
Splenic infarction is tissue death within the spleen, caused by a blockage of blood supply to a segment of the organ. This can occur in several situations. It's quite common in spleens that are massively enlarged, such as in myeloproliferative syndromes or severe portal hypertension.
Why does enlargement cause infarcts?
Well, the sheer size and congestion can compromise blood flow to certain areas, leading to localized ischemia.
Makes sense. Other causes of blood flow blockage.
Vascular occlusion can also result from previous surgery, like procedures near the splenic vessels that might damage them, or from direct compression or thrombosis of the splenic vein or artery, often related to pancreatic disease. And sickle cell disease is a classic cause.
Right, the sickled cells blocking vessels.
Exactly. The rigid sickled cells can block small vessels, leading to repeated microinfarcts and eventually, as we discussed, autosplenectomy.
What are the symptoms? Is it always painful?
Splenic infarcts can be completely asymptomatic, or they can cause acute pain, typically in the left upper quadrant of the abdomen, which may radiate to the left shoulder tip due to irritation of the diaphragm.
How is it diagnosed? Can you see it on a scan?
Contrast-enhanced CT scan is the definitive diagnostic tool. It shows a characteristic wedge-shaped area within the spleen that does not enhance with contrast, indicating lack of blood flow to that region. The text provides an image showing this typical appearance.
And treatment for an infarct? Is it usually surgery?
Management is usually conservative, focusing on pain control and treating the underlying condition causing the infarct. Splenectomy is rarely required, primarily reserved for complicated cases, such as if the infarct becomes infected and forms a splenic abscess.
Okay. Moving on to splenic rupture due to trauma. This is probably what most people think of regarding serious splenic injury.
It's the most common reason for emergency splenectomy worldwide. The spleen is the most frequently injured intra-abdominal organ after the liver in cases of blunt abdominal trauma, especially injuries to the left upper quadrant. It should be high on the suspicion list in anyone presenting after such an injury.
And it can also happen during surgery itself. Iatrogenic injury.
Yes, iatrogenic injury caused by surgery is unfortunately a frequent complication of operations performed in the left upper abdomen, particularly procedures involving the stomach, colon, specifically the splenic flexure, distal pancreas or diaphragm, where adhesions might make dissection difficult and increase the risk of inadvertently damaging the spleen.
How do doctors assess the severity of a traumatic splenic injury? Is there a scale?
Yes, traumatic splenic injuries are graded based on their severity, typically using a 5-grade scale established by organizations like the American Association for the Surgery of Trauma. This grading is usually determined by contrast-enhanced CT scan, which is the critical investigation in hemodynamically stable trauma patients.
What do the grades represent?
The grades range from grade 1, minor subcapsular hematoma or superficial laceration, up to grade 5, shattered spleen or major active bleeding from the hilum. The text includes a table outlining these grades.
And how is traumatic rupture managed? What's the priority?
The initial priority in managing blunt trauma patients is always vigorous resuscitation to stabilize their hemodynamic status. Once the patient is stable, the management strategy for the splenic injury depends on the grade of the injury and whether there is ongoing bleeding.
When is surgery splenectomy necessary?
Splenectomy is typically required for higher grade injuries, particularly grade 4 or 5, or when there is active, life-threatening bleeding that cannot be controlled otherwise. In a hemodynamically unstable patient, immediate surgical exploration via laparotomy and removal of the spleen is often the only option to control the bleeding.
Are there options to try and save the spleen in trauma? Is conservation possible?
Yes, and this is where conservation comes in. In hemodynamically stable patients with lower grade injuries, non-operative management is increasingly preferred. This can involve observation alone, or for higher grade injuries with active bleeding that isn't immediately life-threatening, splenic angiography, followed by embolization of the bleeding vessels.
So blocking the bleeding vessel without major surgery.
Exactly. This technique can effectively stop the bleeding and potentially save the spleen. However, it's absolutely critical that attempting non-operative management with embolization does not delay surgical intervention if the patient is unstable or deteriorates. Stability is the deciding factor.
That approach makes complete sense. Stabilize first, then assess if conservation is possible. The text also mentions rupture of a malarial spleen specifically.
This is a specific problem seen in tropical countries, endemic for malaria, where the spleen can become massively enlarged and fragile due to chronic infection, a condition part of tropical splenomegaly syndrome.
So the enlarged spleen is just more vulnerable.
Yes, these huge engorged spleens are highly susceptible to rupture, sometimes even after seemingly minor abdominal trauma, or occasionally spontaneously.
And the presentation can be tricky, maybe delayed.
Yes, a delayed presentation of symptoms after a relatively minor injury is not uncommon, making it a diagnostic challenge.
How is a ruptured malarial spleen managed? Is it the same as other trauma?
If radiological embolization facilities are available and the patient is stable enough, that can be attempted. However, surgical splenectomy might be the necessary treatment, especially given the risk of the hematoma around the spleen rupturing into the general peritoneal cavity, which has a worse prognosis. It's often considered proactively if a perisplenic hematoma is detected.
And surgically, is this different from a standard traumatic rupture? Is it harder?
It can be much more surgically challenging. The spleen is often massive, friable, and surrounded by inflammatory adhesions. The text recommends a specific technique.
Oh, what's the key?
Early ligation of the splenic vessels along the superior border of the pancreas body before attempting to mobilize or disturb the large perisplenic hematoma. This helps control the main blood supply before disrupting the fragile tissues, minimizing blood loss during the more difficult part of the dissection. This approach is a key pearl for operating on these specific cases.
Fascinating how the underlying disease impacts the surgical approach. Let's transition to the broader topic of splenic enlargement, splenomegaly, and the syndrome of hypersplenism.
Splenomegaly, as we've established, is a common clinical finding, a signpost pointing towards a wide variety of potential underlying diseases, from infections and blood disorders to circulatory problems and cancers.
And we know it has to be quite enlarged to be palpable, about 3 times normal size.
Right, and this is an important point. Many conditions that affect the spleen and cause low blood counts, like ITP, might cause some splenic enlargement, but the spleen remains non-palpable. Gross, easily palpable splenomegaly often directs the diagnostic focus towards specific conditions known to cause significant enlargement.
And importantly, the text reiterates that splenectomy is not required as the primary treatment for most conditions that cause splenomegaly. It's not the first step, usually.
That's a crucial takeaway. Splenectomy is reserved for specific situations where the splenomegaly is causing significant problems that cannot be managed otherwise, or where the underlying condition requires splenic removal as part of its treatment or for diagnosis.
This leads us to hypersplenism. What defines this syndrome exactly?
Hypersplenism is a clinical syndrome characterized by 4 key components working together. First, there is splenic enlargement. Second, there is a reduction in the peripheral blood counts of 1 or more cell lines, anemia, leukopenia, or thrombocytopenia.
Okay, low counts.
Third, the bone marrow shows a compensatory hyperplasia, meaning it's actively producing more blood cells, trying to keep up with the excessive destruction or sequestration occurring in the spleen.
So the marrow is working overtime.
Right. And fourth, the blood count abnormalities improve after splenectomy.
So it's the enlarged spleen being overly active, causing low blood counts despite the bone marrow trying hard to compensate. And removing the spleen fixes it.
Exactly. And the decision to perform splenectomy for hypersplenism involves a careful assessment of the severity of the low blood counts and associated symptoms, weighing the potential benefits of improving the counts against the long-term risks of being a splenic.
Let's go through the specific causes of splenomegaly listed in the text and see where hypersplenism or other splenic involvement might lead to intervention. The text details various infective causes first.
Yes, infections are a major category. These include bacterial infections like typhoid paratyphoid fever, typhus, tuberculosis, psittacosis, systemic septicemia, and localized splenic abscesses.
Okay.
Spirochetal infections like Weil's disease, named after Adolf Weil. Viral infections such as infectious mononucleosis, mono, and HIV, which can sometimes present with related thrombocytopenia. And protozoal parasitic infections like malaria, schistosomiasis, trypanosomiasis, Kala-Azar, visceral leishmaniasis, and hydatid cysts.
Let's focus on a few of these. Splenic abscess, you mentioned it earlier with infarcts. Where do they come from?
A splenic abscess is a collection of pus in the spleen. It can arise from the spread of infection through the bloodstream from other sites, like infected heart valves, emboli, bone infections, osteomyelitis, ear infections, otitis media, or infections after childbirth, puerperal sepsis. It can also be linked to typhoid fever, or in the context of general surgery, can complicate pancreatic necrosis or other severe intra-abdominal infections. The danger is the risk of the abscess rupturing.
Right, causing peritonitis.
Exactly, leading to a left subphrenic abscess or widespread peritonitis.
Treatment for a splenic abscess, is it always surgery?
Management involves treating the underlying infection. The preferred approach for draining the abscess is usually percutaneous drainage, inserting a needle or catheter through the skin, guided by radiology, like ultrasound or CT.
So draining it without open surgery?
Right. Splenectomy is generally reserved for cases where percutaneous drainage isn't successful or possible. The text shows a multiloculated abscess managed this way.
Tuberculosis affecting the spleen, is that common?
It can happen. Tuberculosis can affect the spleen, sometimes presenting as isolated splenic involvement or as part of widespread disseminated TB. It should be considered in younger adults with splenomegaly accompanied by general symptoms like weakness, weight loss, and fever. It can sometimes cause portal hypertension, or rarely present as a cold abscess, an abscess without typical inflammatory signs. On imaging, CT might show small, ring-enhancing lesions, while MRI might show multiple hypointense lesions.
Is splenectomy needed for splenic TB?
No, standard treatment is multi-drug anti-tuberculosis chemotherapy for 12-18 months. Splenectomy is generally not required and can be surgically difficult due to inflammatory adhesions if it were needed for another reason. The diagnosis is usually made by characteristic histological findings, like epithelioid cell granulomas, seen if a biopsy or splenectomy was performed for diagnosis or other indication.
Tropical splenomegaly tied to malaria and other tropical infections. You mentioned this causing massive enlargement.
Yes, this refers to the massive splenic enlargement commonly seen in tropical regions. Chronic exposure to infections like malaria, Kala-Azar, or schistosomiasis are primary causes. Sometimes the exact trigger is unclear, potentially related to occult infection or malnutrition.
When would splenectomy be considered here?
Splenectomy might be considered in these huge spleens if they cause severe anemia due to hypersplenism, significant local symptoms from their sheer size, or if there's a perceived risk of rupture. Crucially, if living in an endemic area, lifelong antimalarial therapy is often required even after splenectomy to prevent recurrence of the syndrome. Sir Patrick Manson, the father of tropical medicine, was instrumental in understanding these diseases.
Schistosomiasis is another significant tropical cause you highlighted. What's the mechanism there?
Yes, this parasitic infection, prevalent in parts of Africa, Asia, and South America, caused by flatworms like Schistosoma mansoni or Schistosoma hematobium. Splenomegaly here can be caused by portal hypertension resulting from associated liver fibrosis, cirrhosis or non-cirrhotic portal fibrosis, or by hyperplasia of the spleen itself. This is phagocytosis of the worms, ova, and toxins. It can occur at any age. Diagnosis involves finding parasite eggs in urine or feces, abnormal liver tests, and often hyperchromic anemia.
Does treating the parasite with medication shrink the spleen?
No. Successful medical treatment of the parasitic infection does not typically cause regression of the splenomegaly or reversal of the portal hypertension.
So the damage is done.
Right. Splenectomy might be indicated for a persistently painful, enlarged spleen, or as part of a surgical procedure to manage severe portal hypertension from the associated liver disease, such as devascularization procedures to reduce blood flow to varices.
Okay, moving to blood diseases, a large category where the spleen's filter function is often central to the problem. Lots of conditions here.
Indeed. This includes acute and chronic leukemias, idiopathic thrombocytopenic purpura, ITP, hereditary serocytosis, pernicious anemia, autoimmune hemolytic anemia, polycythemia vera, thalassemia, erythroblastosis fetalis, hemolytic disease of the newborn, and sickle cell disease.
Leukemia first. How is the spleen involved?
Splenomegaly is a common feature of many leukemias, particularly chronic leukemias, due to infiltration of the spleen by malignant white blood cells. Diagnosis is made via blood and bone marrow examination.
Is splenectomy a treatment for leukemia?
No, splenectomy is not a primary treatment for leukemia itself, but may be considered in specific circumstances, such as managing severe hypersplenism causing debilitating low blood counts in the chronic phase of chronic granulocytic leukemia.
Okay. Idiopathic thrombocytopenic purpura, ITP. This is a big one for splenectomy, you said.
It is a classic indication for splenectomy. ITP, or immune thrombocytopenic purpura, is an autoimmune disorder where the body produces antibodies, specifically antiplatelet IgG antibodies against its own platelets.
So the body attacks its own platelets?
Correct. These antibody-coated platelets are then rapidly destroyed, primarily by macrophages in the spleen, leading to isolated thrombocytopenia, a low platelet count in a patient with otherwise normal blood counts and bone marrow.
Are there acute and chronic forms, like a sudden onset versus long-term?
Yes, there's an acute form, more common in children, often triggered by a viral infection, which typically resolves spontaneously. The chronic form is more common in adults, lasting longer than 6 months without a clear preceding event.
Who gets the chronic form typically?
The chronic adult form is more frequent in women aged 15-50 and can be associated with other autoimmune diseases like systemic lupus erythematosus, SLE, or certain lymphoid malignancies like chronic lymphatic leukemia or Hodgkin's disease, named after Thomas Hodgkin. The childhood form affects boys and girls equally, usually presenting before age 5.
What are the symptoms of low platelets? What does that look like?
Symptoms relate to increased bleeding tendency. You see purpuric patches, ecchymosis bruising, and petechiae, tiny pinpoint hemorrhages on the skin and mucous membranes, especially after minor pressure or trauma.
Okay.
Spontaneous bleeding from mucous membranes, such as nosebleeds, epistaxis, or heavy menstrual periods, menorrhagia, is common. Prolonged bleeding from minor cuts can also occur. More severe internal bleeding, like gastrointestinal, urinary tract, or into joints, hemarthrosis, is fortunately rare.
And the most serious risk? What's the worst outcome?
The most feared, though uncommon, complication and the most frequent cause of death is intracranial hemorrhage bleeding into the brain.
How is ITP diagnosed? How do you confirm it?
Diagnosis is suspected clinically by unexplained bruising and petechia, sometimes with a positive tourniquet test. Lab tests show a low platelet count, often below 60 by 109L, on the peripheral blood film. Crucially, the bone marrow aspiration shows a normal or increased number of megakaryocytes, the platelet-producing cells.
So the factory is working, but the products are being destroyed.
Exactly. It confirms that the issue is platelet destruction, not production failure. And importantly, the spleen is often normal size or only slightly enlarged in ITP and is palpable in less than 10% of patients. Gross splenomegaly suggests an alternative diagnosis.
Treatment approach. What's done first?
In children with acute ITP, observation is common as spontaneous resolution is frequent. In adults and children, a short course of corticosteroids often improves platelet counts, but prolonged use is avoided.
And splenectomy. When does that come into play?
Splenectomy is the mainstay treatment for refractory or relapsing ITP, meaning the patient doesn't respond adequately to initial medical treatment, like steroids or other agents, or improves, but then suffers a significant relapse.
Because the spleen is the main site of destruction.
Yes, removing it is highly effective. The text notes that up to 2/3 of patients are cured, platelet counts normalize and stay normal, and another 15% show significant improvement. Patients who initially responded well to steroids but then relapsed are generally good candidates for a favorable response to splenectomy.
And laparoscopic splenectomy is preferred for ITP.
Yes, minimally invasive laparoscopic splenectomy is now the standard approach for ITP because the spleen is typically not massively enlarged and is not usually adherent, making it well suited for this technique.
And the accessory spleens, again, critically important here.
This is one of the classic scenarios where finding and removing accessory splenic tissue, pedunculi, is absolutely critical during the splenectomy. If left behind, an accessory spleen can grow and lead to recurrence of the thrombocytopenia, necessitating another operation.
What about blood transfusions around surgery for ITP if platelets are dangerously low?
In cases of very severe, life-threatening thrombocytopenia, platelet transfusions might be given acutely before surgery to temporarily boost counts and reduce bleeding risk. However, platelet transfusions are often most effective and utilized during or immediately after surgery, particularly once the splenic vessels have been ligated.
Why then?
As the spleen would otherwise rapidly destroy the transfused platelets before its removal. Giving them after ligation maximizes their benefit.
Makes sense.
Let's turn to the hemolytic anemias where splenectomy can be a key treatment. The text lists 4: hereditary spherocytosis, acquired autoimmune hemolytic anemia, thalassemia, and sickle cell disease. We covered spherocytosis mechanism earlier, but let's reiterate why splenectomy is key there.
Right. Hereditary spherocytosis is a genetic defect
Leading to abnormally shaped, rigid red blood cells that are prematurely destroyed in the spleen's filter. Splenectomy removes this primary site of destruction, allowing the abnormal cells to circulate longer, significantly improving the anemia and reducing symptoms like jaundice and the risk of pigment gallstones.
And the text says it's recommended for everyone with the condition.
The text explicitly states that all patients with hereditary spherocytosis should be treated by splenectomy, ideally delaying in young children until age 6 to minimize post-splenectomy infection risk, but performing it before gallstones develop, requiring pre-op ultrasound.
Okay. Acquired autoimmune hemolytic anemia, AIHA. How is that different?
AIHA is where the body produces antibodies or uses complement proteins against its own red blood cells, leading to their rapid destruction. The spleen, with its macrophages, is a major site for clearing these antibody-coated red cells. AIHA can be triggered by drugs, infections, or associated with other conditions.
Diagnosis.
The key diagnostic test is the direct Coombs test, named after Robin Coombs, which detects antibodies on the red cell surface.
And splenectomy's role here, is it first line?
Corticosteroids are often the first-line treatment. Splenectomy is considered if the patient doesn't respond adequately to medical therapy, develops complications from long-term steroids, or if steroids are contraindicated. By removing a major site of red cell destruction, splenectomy improves red cell survival in about 80% of patients.
Thalassemia, a hereditary defect in hemoglobin production. How does the spleen fit in?
Thalassemia, like beta thalassemia major, Cooley's anemia, named after Thomas Cooley, involves reduced synthesis of hemoglobin chains. This leads to unstable hemoglobin and intracellular precipitates, Heinz bodies, in the red cells, making them fragile and prone to premature destruction. The spleen removes these abnormal cells and cells containing Heinz bodies.
When is splenectomy used here? It doesn't fix the underlying problem.
No, it doesn't. Splenectomy can be beneficial in patients with severe thalassemia major who require very frequent blood transfusions, as hypersplenism, the enlarged spleen destroying transfused cells, often contributes to the anemia. It can reduce the need for transfusions and help if the patient develops antibodies against transfused cells.
Finally, sickle cell disease. You mentioned autosplenectomy earlier, the spleen destroying itself.
Yes, in sickle cell disease, the abnormal HBS causes red cells to sickle in low oxygen conditions, obstructing blood flow and causing infarcts, which often damage and shrink the spleen over time, autosplenectomy, by late childhood or adolescence.
So the spleen might already be gone functionally.
Often, yes. However, before this occurs, or in some specific circumstances, the spleen can become acutely or chronically enlarged and sequester large numbers of red cells.
So when is splenectomy indicated in sickle cell? It sounds like it might not be needed often.
It's beneficial in a limited number of patients with sickle cell disease, primarily those with symptomatic chronic hypersplenism, where excessive splenic sequestration significantly worsens the anemia, requiring frequent transfusions. There's also an acute splenic sequestration crisis, particularly in young children with functional spleens, often triggered by infection, which requires emergency management and sometimes splenectomy. The text mentions names like Neisser and Escherich in a context related to potential infectious triggers, though not directly linked to the sickle cell mechanism itself. Avoiding hypoxia is critical in all sickle cell patients, including during surgery.
The text also lists metabolic disorders like porphyria and Gaucher's disease. Any role for splenectomy?
Porphyria involves errors in hemoglobin metabolism. Splenectomy has little to no role in treating porphyria. Gaucher's disease, however, is a lipid storage disorder, where a lipid called glucose cerebroside accumulates in reticuloendothelial cells, particularly in the spleen, liver, and bone marrow.
And this makes the spleen huge.
This accumulation can lead to massive splenic enlargement. Indeed, some of the largest spleens seen are in Gaucher's patients. Associated signs include yellowish-brown skin discoloration and conjunctival thickening, pinguecula.
Diagnosis and treatment for Gaucher's spleen involvement.
Diagnosis is confirmed by finding characteristic Gaucher cells in bone marrow biopsies. Enzyme replacement therapy is the primary treatment for the underlying metabolic defect. Splenectomy in Gaucher's disease is reserved only for managing severe symptoms directly caused by the massive splenomegaly.
So only if the size itself is the problem.
Right, such as pain, abdominal distension, or significant hypersplenism, but it doesn't cure the metabolic disease. Philippe Charles Ernest Gaucher was the first to describe this condition.
Circulatory causes include portal hypertension, which we've touched on several times. The spleen always gets big then.
Yes, splenomegaly is an invariable feature of portal hypertension, whether caused by liver cirrhosis, schistosomiasis, or extrahepatic portal vein obstruction. The elevated pressure in the portal system backs up into the splenic vein, causing congestion and enlargement of the spleen.
And this leads to hypersplenism symptoms, low counts.
Typically, yes. Portal hypertension commonly causes thrombocytopenia and granulocytopenia, low white blood cells, due to the sequestration and accelerated turnover of these cells in the congested spleen. These blood count abnormalities can improve if the portal hypertension is effectively treated, for example, by liver transplantation or shunt surgery.
When would splenectomy be considered in portal hypertension?
Splenectomy is not a routine treatment for portal hypertension itself, which requires addressing the underlying liver disease or portal vein blockage. However, it is indicated in specific cases of segmental portal hypertension.
The type affecting just the splenic vein.
Exactly. Often caused by isolated splenic vein occlusion from pancreatic issues, for example, that results in symptomatic esophagogastric varices, swollen veins in the esophagus or stomach that are prone to bleeding. Removing the spleen and its congested venous drainage can decompress these varices. It might also be performed alone for massive splenomegaly associated with extrahepatic portal vein obstruction, or combined with a proximal renal shunt connecting the splenic vein to the left renal vein to bypass the blockage. The text refers to detailed variceal surgery in another chapter, but clarifies the spleen's role here.
Collagen diseases like Felty syndrome are also mentioned. What's that?
Felty syndrome is a specific combination seen in patients with long-standing rheumatoid arthritis, severe leukopenia, low white blood cells, accompanied by splenomegaly. It's named after Augustus Roy Felty.
Does removing the spleen help in Felties?
Splenectomy and Felty syndrome generally provides only a transient, temporary improvement in the white blood cell count. Interestingly, it has been observed that splenectomy might sometimes make the underlying rheumatoid arthritis more responsive to corticosteroid therapy that was previously ineffective.
We've covered non-parasitic cysts already. What about neoplasms, tumors in the spleen? Are they common?
Primary tumors of the spleen are relatively rare. The most common benign tumor is a hemangioma, a tangle of blood vessels. Very rarely, a benign hemangioma can undergo malignant change to become a hemangiosarcoma. The spleen is also an uncommon site for metastases, the spread of cancer from other organs.
What's the most common malignant cause of splenic enlargement then?
Lymphoma is the most frequent neoplastic disease causing significant splenic enlargement, either as the primary site of involvement or as part of widespread disease.
What is the role of splenectomy in lymphoma? Is it for treatment or diagnosis?
Splenectomy can serve a few roles in lymphoma. It can be used to obtain a definitive histological diagnosis, particularly if there are no easily accessible enlarged lymph nodes elsewhere in the body. It can also be performed palliatively to relieve symptoms caused by gross splenomegaly, such as pain or discomfort from its size, or to improve low blood counts due to hypersplenism.
Has the need for surgical diagnosis changed over time with better imaging?
Yes, with advancements in imaging, CT, PT, CT, and image-guided biopsies, the need for staging laparotomy, a major abdominal surgery, including splenectomy and lymph node biopsies to determine the extent of disease, has significantly decreased.
But it's still done sometimes.
Yes, splenectomy remains relevant when a definitive tissue diagnosis from an intra-abdominal site is needed, and that diagnosis would dramatically alter the patient's treatment plan. It's still considered an integral part of staging in certain lymphomas, especially if involvement isn't clear elsewhere, because finding lymphoma in the spleen impacts the treatment strategy.
Finally, myelofibrosis. What happens there?
Myelofibrosis is a chronic myeloproliferative disorder where the bone marrow becomes scarred and fibrotic, losing its ability to produce blood cells effectively. The body compensates by starting blood cell production in other organs, particularly the spleen and liver.
Extramedullary hematopoiesis again.
Right, leading to massive enlargement of both hepatosplenomegaly. Patients, typically over 50, experience severe symptoms due to the sheer bulk of the spleen and liver, or from painful splenic infarcts.
Does splenectomy help in myelofibrosis? What's the goal?
Splenectomy in myelofibrosis is primarily palliative. It can significantly reduce the need for frequent blood transfusions, as the enlarged spleen can be sequestering red cells, and provide considerable relief from the discomfort and pain caused by the massive splenomegaly. The text includes an MRI showing the dramatic size of the spleen in myelofibrosis.
We have truly gone deep into the myriad ways diseases can involve the spleen and how its specific functions contribute to the pathology. Now let's turn to the actual surgical procedure of removing the splenectomy.
Splenectomy is a significant surgical intervention, and as we've seen throughout this discussion, it's now approached with much greater respect for the organ's vital functions compared to historical attitudes.
Let's summarize the key indications for splenectomy based on what we've discussed. When is it really necessary?
The main indications, as outlined, include trauma to the spleen, accidental blunt or penetrating trauma, or iatrogenic injury during other abdominal surgery. Oncological reasons, as part of a larger cancer resection, like for certain gastric or pancreatic cancers involving the spleen, or for diagnosis, symptom management, and lymphoma.
Right.
Hematological disorders, conditions like hereditary spherocytosis, ITP that is refractory to medical treatment, certain hemolytic anemias and other causes of hypersplenism, and in specific situations related to portal hypertension, particularly to manage varices and segmental portal hypertension.
And just to reiterate, based on our deep dive, splenectomy is specifically the recommended treatment for all patients with hereditary spherocytosis, timing matters, for refractory or relapsing ITP, in carefully selected patients with sickle cell disease experiencing significant hypersplenism, for severe symptoms of massive splenomegaly and Gaucher's disease, for segmental portal hypertension with symptomatic varices, and to relieve symptoms like pain and reduce transfusion needs in myelofibrosis. For most other causes of splenomegaly, splenectomy is not the primary treatment.
Correct. Those are the specific, well-defined scenarios where the benefits of removing the spleen to address a severe, unmanageable problem outweigh the risks of being a splenic.
What kind of preparation is needed before a splenectomy, especially if blood counts are low?
Preoperative preparation is important, especially if the patient has blood count abnormalities or a bleeding tendency due to their underlying condition. This might involve transfusing blood to correct anemia, fresh frozen plasma, cryoprecipitate, or platelets to improve coagulation and platelet counts.
Getting them optimized for surgery.
Exactly. Coagulation profiles should be checked and normalized if possible. Platelets should be readily available in the operating room, particularly for patients with severe thrombocytopenia, for administration during or immediately after securing the splenic vessels.
And beyond blood products, anything else critical beforehand?
Standard antibiotic prophylaxis for surgery is given, but critically, attention must be paid to planning the vaccinations and potential antibiotic prophylaxis required long-term to prevent post-splenectomy sepsis, which is a major concern we'll get to.
Okay, let's walk through the technique for an open splenectomy first. How is that done?
For an open approach, the surgeon typically makes an incision in the abdomen. A midline incision or a transverse incision below the left costal margin, left subcostal, are common choices. In cases of extremely massive adherent spleens, a thoracoabdominal incision might occasionally be necessary, though this is less frequent now with alternative approaches.
In the patient position.
The patient is usually positioned flat on their back, supine.
What are the main steps inside once the surgeon is in?
After opening the abdomen, a nasogastric tube is usually inserted to decompress the stomach, keeping it out of the way. In an elective case, the surgeon typically starts by carefully dissecting and opening the gastrosplenic ligament, identifying and ligating the short gastric vessels running within it.
Dividing that connection to the stomach.
Right. Then they move posteriorly to secure the main splenic vessels. A key step is to ligate the splenic artery and vein early, often at the superior border of the pancreas body, using suture ligatures. Next, they divide the posterior leaf of the lanurenal ligament, often using long curved scissors like Metzenbaum scissors.
Okay.
This dissection helps to mobilize the spleen medially towards the midline, along with the tail and sometimes part of the body at the pancreas, freeing it from the kidney and diaphragm.
Getting it free from its attachment.
Exactly. The pancreas tail is carefully separated from the main hilar vessels. The vessels entering the hilum are then doubly ligated and divided individually to ensure secure hemostasis.
And the accessory spleens. Can't forget those.
A critical, non-negotiable step during open splenectomy for hematological disease is a thorough, careful search for and removal of any accessory splenic tissue, splenomegaly. These are most commonly found in the splenic hilum or embedded within the omentum or ligaments. Failure to remove them risks disease recurrence.
Got it. And then closure.
Once the spleen and any accessory tissue are removed and hemostasis is confirmed, the abdomen is closed. Generally, a drainage tube is not needed after an elective splenectomy.
You mentioned earlier the possibility of splenic conservation. How does the surgery differ if you're trying to save part of the spleen? Is that much harder?
If splenic conservation is possible, usually for localized trauma or a cyst confined to one area, the surgery aims to remove only the affected portion. Because the splenic artery divides into segmental branches, the surgeon can identify the boundaries between segments.
Ah, using that segmental anatomy.
Right. They would then resect the damaged or diseased segment, carefully ligating or clipping the intrasplenic vessels within the cut surface to control bleeding. Topical hemostatic agents can also be applied to the raw surface. This partial splenectomy approach leverages the organ's anatomy to preserve as much functional splenic tissue as possible.
That's a much more nuanced approach than just total removal. Now let's talk about the more common modern approach for many elective cases. Laparoscopic splenectomy. How does that work?
Laparoscopic, or minimally invasive splenectomy, has become the standard of care for many conditions, particularly those where the spleen is not massively enlarged or heavily stuck down, such as ITP. The goal is the same, remove the spleen, but it's done through small incisions using a camera and specialized instruments.
How is the patient positioned differently for laparoscopy?
The patient is typically placed on their right side, right lateral decubitus position, to allow gravity to help pull the abdominal contents away and expose the left upper quadrant between the hip bone and the ribs.
Okay, and the ports, the small incisions.
The placement of the small incisions, called ports, varies depending on the surgeon's technique and the patient's size. The abdomen is inflated with carbon dioxide gas, insufflation, through an initial small incision, perhaps in the left midclavicular line below the ribs. Then other trocars, essentially sleeves to pass instruments through, are inserted, for example, a port below the xiphoid process and a larger 12 mm port in the posterior axillary line.
And the key steps during laparoscopic removal, what are the surgeons doing inside?
The surgeon uses the camera to visualize the abdomen. They typically start by dividing the splenomegaly ligament, which attaches the lower pole of the spleen to the colon, to gain initial access and mobilize the spleen. Then they carefully separate the spleen from its attachments to the left kidney and the diaphragm using cautery or dissecting instruments.
Okay.
The space between the splenic hilum and the pancreatic tail is enlarged. The spleen is then elevated to expose the splenic hilum from behind. The splenic vessels at the hilum are secured and divided.
How are the vessels secured laparoscopically with staples?
Yes, a key tool here is the endoscopic vascular stapler. This device can simultaneously clamp, cut, and staple the vessels and surrounding tissue bundle. It often requires 2 or 3 applications to completely divide the hilum and the short gastric vessels supplying the spleen.
Right.
Once the hilum is divided and any remaining attachments to the diaphragm are cut, the spleen is free.
How is the spleen removed through the small incisions then? It's still a whole organ.
The spleen is placed into a special self-retaining bag inside the abdomen. This bag is then pulled out through one of the larger port incisions off of the 12 mm port site, which might need to be slightly enlarged to accommodate the spleen. Sometimes the spleen is morcellated or broken up within the bag for easier removal. It's appropriate for the condition being treated.
So, whether open or laparoscopic, it's a complex procedure involving careful anatomical dissection and securing major blood vessels. But the story doesn't end when the spleen is out. What are the potential complications after splenectomy?
Postoperative complications exist for any surgery, but splenectomy has some specific ones that require careful attention. Immediate specific complications include hemorrhage, if a ligature on a vessel slips, or if there's bleeding from the raw surfaces left behind.
Okay, bleeding is always a risk.
Respiratory complications are common due to the spleen's location under the diaphragm, including left basal atelectasis, collapse of the lower part of the left lung, and pleural effusion, fluid accumulation around the left lung.
What about damage to nearby organs?
Injury to adjacent structures is also a risk during the dissection, particularly the stomach. Damage during short gastric vessel ligation can lead to a gastric fistula, and the tail of the pancreas. Injury during hilar dissection can result in pancreatitis, an abscess, or a pancreatic fistula. Less common gastric issues can include hematemesis, vomiting blood, from mucosal injury or gastric dilatation, though these are rare.
What happens to blood counts after splenectomy? You mentioned the reservoir function earlier. Does the platelet count go up?
Yes, one common postoperative change is thrombocytosis, an increase in the platelet count. Because the spleen is no longer filtering out aging platelets, their number in circulation rises.
Is that dangerous? High platelets?
If the platelet count becomes very high, typically above 1 million, 1 by 106 millimole, there's an increased risk of thrombosis blood clot formation. Prophylactic low-dose aspirin is often recommended in these cases, although the ideal strategy for thromboprophylaxis in all post-splenectomy patients isn't fully established, and studies show an increased risk of DVT and pulmonary embolism long-term.
And the major concern, the real clinical danger, highlighted in the text post-splenectomy septicemia, or OPSI. This sounds serious.
Opportunistic post-splenectomy infection, or OPSI, is the most serious long-term complication, and the one surgeons and patients are most vigilant about. Patients without a functional spleen have a significantly increased risk, about 3-fold higher, of developing overwhelming, rapidly progressive infections, particularly pneumonia, meningitis, and severe systemic sepsis.
Which organisms are the main culprits? We talked about the encapsulated ones.
Exactly. The most common causative organisms are encapsulated bacteria. Streptococcus pneumonia is by far the most frequent, followed by Neisseria meningitidis and Haemophilus influenza type B. Escherichia coli is also listed.
And the text mentions one from animal bites.
Yes, it specifically calls out Capnocytophaga canamorsis, a bacterium found in the mouths of dogs and cats, which can cause severe, rapidly progressive infection after an animal bite in splenic individuals.
Who is at highest risk for OPSI? Is it everyone equally?
The risk is greater in younger patients, those receiving chemotherapy or radiotherapy, and those whose splenectomy was performed for underlying conditions like thalassemia, sickle cell disease, or autoimmune hemolytic anemia thrombocytopenia. The risk is highest in the first 2-3 years after surgery, but persists for the patient's entire life.
So how is this major risk managed? What are the essential prevention strategies? It sounds like prevention is key.
Published guidelines emphasize that most post-splenectomy infections are preventable through a combination of key measures: rigorous, timely immunization, long-term antibiotic prophylaxis, though its role in adults is debated, comprehensive patient education about the risks and symptoms, and prompt treatment of any suspected infection.
Let's detail the vaccination protocol. When should people get vaccinated?
Vaccination is the cornerstone. If splenectomy is planned electively, all recommended vaccinations should be given at least 2 weeks before the surgery to allow time for the immune system to develop protective antibodies.
And if it's an emergency, like trauma?
If the splenectomy is performed emergently due to trauma, vaccination should be administered as soon as the patient has recovered, ideally before they are discharged from the hospital.
Which vaccines are essential? Which specific bugs are targeted?
Vaccination against Streptococcus pneumococcus is mandatory for anyone over 2 years old, and it needs to be repeated every 5 years. Vaccination against Neisseria meningitidis, meningococcus C, is also recommended, repeated every 5 years. And vaccination against Haemophilus influenza type B, HIB, is recommended regardless of age, typically repeated every 10 years. The meningococcus and HIB vaccines are often given as a combined vaccine.
And the flu shot?
Additionally, yearly influenza vaccination is recommended, as flu can sometimes lead to secondary bacterial infections that could be more severe without a spleen.
That's a specific regimen targeting those key encapsulated bacteria. Does it guarantee protection?
It's about providing the immune system with some level of defense against the pathogens the patient is now most vulnerable to. It's worth noting that antibody responses to these vaccines can be less robust when given after splenectomy compared to when the spleen is intact, but they still offer significant protection in most individuals. However, protection is never absolutely guaranteed.
What about antibiotic prophylaxis, daily antibiotics? Is that recommended for everyone?
The benefit of long-term daily prophylactic antibiotics, especially in adults, is debated due to concerns about compliance and the development of antibiotic resistance. However, there are specific recommendations. Children splenectomized before age 5 should receive daily penicillin prophylaxis until age 10.
Okay.
Older children should continue until at least 16. In adults, prophylaxis is less consistently recommended for life, but giving it for the first 2-3 years after splenectomy, when the risk is highest, is considered reasonable. Patients who are immunosuppressed for other reasons should definitely receive lifelong prophylaxis.
And if a patient with a history of splenectomy gets sick, what should happen?
Any fever or sign of potential infection in an asplenic patient should be treated as a medical emergency. They need prompt assessment and often immediate treatment with broad-spectrum antibiotics, usually intravenously.
Which antibiotics?
The antibiotic choices for treating suspected infections in these patients include the same antibiotics used for prophylaxis: penicillin, erythromycin, amoxicillin, coamoxiclav, plus a third-generation cephalosporin like cefotaxime or ceftriaxone, or chloramphenicol if there are allergies to penicillin or cephalosporins.
Beyond vaccinations and prophylaxis, what responsibility does the patient have? What do they need to know?
Patient education is critical. Asplenic patients must be fully aware of their increased risk of infection and understand the importance of seeking immediate medical attention for any signs of illness, particularly fever. They should carry a medical alert card or bracelet, identifying them as having no spleen and list their vaccination history. They also need specific advice regarding travel, especially to areas with high rates of malaria or other endemic infections, and handling of animals due to the risk of Capnos cytophaga infection from animal bites.
That comprehensive prevention strategy underscores just how vital the spleen is and how much effort goes into mitigating the risks once it's removed. It's a lifelong consideration.
It truly highlights the organ's indispensable contribution to our immune defenses and blood health.
And this brings us full circle back to the idea of splenic conservation we touched on earlier, saving it if possible.
Yes. Given the recognized importance of maintaining splenic function and the inherent risks associated with splenectomy, preserving the spleen either entirely or partially has become the preferred approach whenever clinically feasible and safe for the patient.
And based on the text, where is conservation most often feasible? We mentioned trauma and cysts.
As we discussed, conservation is a key strategy in the management of certain splenic injuries, particularly lower-grade traumatic injuries where bleeding can be controlled with non-operative means like angiography and embolization in a stable patient. Partial splenectomy may also be feasible for certain localized benign lesions like cysts or hamartomas affecting only a segment of the spleen. The technical feasibility depends on the location and extent of the injury or pathology and the surgeon's expertise.
So the goal now is to save the powerhouse if at all possible, rather than just remove it, a real shift in thinking.
Precisely. It's a shift towards recognizing and preserving the spleen's vital, lifelong contributions to health.
We have gone deep indeed, from the spleen's tiny origins in the embryonic mesogastrium, through its intricate dual pulp architecture, its vital roles in filtering and immunity, the complex ways it's involved in a vast array of diseases, from infections to cancers and blood disorders, how we investigate its problems with sophisticated imaging, and the detailed considerations for surgical removal and its potential complications.
It's a remarkable journey through a remarkable organ. Once misunderstood and underestimated, the spleen now stands revealed as a sophisticated center for immune surveillance, blood cell quality control, and pathogen clearance, deeply intertwined with our systemic health.
Understanding an organ like the spleen at this level, seeing how its microscopic structure enables its unique functions, how disruptions to those functions manifest as specific diseases, and why medical interventions carry particular risks, it really provides an elite perspective on the complexity and interconnectedness of the human body.
It makes you appreciate that even a seemingly quiet organ, tucked away under the ribs, is performing critical jobs we depend on every single day. Absolutely.
It does. What does this deep dive into the spleen make you think about other organs we might take for granted, those parts of the body we rarely consider until something goes wrong? It's a thought that encourages a deeper appreciation for the whole intricate, resilient system.
That's a great question, a question worth pondering. The body is full of hidden wonders, isn't it?
Absolutely, and that's why we keep diving deep. Thanks for joining us.